Fatima Gatela, and I'm a nurse. Talking to you today about some ways that hospitals use data. Before I continue, can I have a quick poll? Does anyone here work in healthcare? What kind of work do you do?
I used to be an analyst at Sutter Health.
Analyst?
Yeah, so data analyst.
Data analyst?
I used to be a program manager at a healthcare startup.
Excellent. Anyone else?
Electronic medical records and yes, and then right now it's Parkinson's disease.
Excellent. So you'll be a little bit familiar with this talk, and maybe you can help me along. A very important caveat before I continue. This topic is so broad that I am not, and I do not claim to be an expert on each and every aspect of it. But the goal of this talk is really for those who are not familiar or have never heard how much data there is in healthcare and what the healthcare industry uses it, specifically hospitals. I wanted to give you a very general overview of what is out there and a glimpse of the many possibilities that can be used with data in healthcare. And also, maybe after the talk, you'll be interested in learning more about the healthcare industry. So here are our learning objectives for today, and we really only have two. At the end of the talk, we'll recognize the general categories in which hospitals use data and identify some examples under each category. Before I start, I wanted to share a little bit about myself. As I mentioned, I am a nurse. I used to be a critical care nurse before I started working as an informatics nurse, which is a nurse that stands at the crossroads between healthcare IT and clinical nursing, so I speak the language of both worlds. I started with electronic health record implementation back in 2010 and have been a consultant between then and now. And now I work at the Health Information Management Department at UC Davis Health, so in the neighborhood. So when you talk about the general categories of data use, specifically for hospitals, there really are so many categories. But for this particular talk, I wanted to focus in on 4 general categories, which is treatment, payment, operations, and compliance to regulations. And as you can see, at the center of it all is always the patient. In healthcare, we always put the patient in the center of all our activities, initiatives, and programs. So when you say treatment, there's various levels of using data for treatment. And the broadest level is also correlated with regulations, which is that there are regulations from the CMS level. Everyone familiar with CMS, Centers for Medicare and Medicaid services, as well as the Health and Human Services Department of the U.S. government. So these regulatory bodies set forth standards, and hospitals who want to participate in the programs of the government have to meet these standards. So, for example, they have their HHS has a core measure set, and the core measure sets measure certain quality standards. So, for example, they might measure hypertension control. And this hypertension control would say, what is the percentage of patients between the ages of 18 to 35 with a diagnosis of high blood pressure, whose blood pressure improved within the measurement period. So as you can see there, whenever patients come into the hospital, their data goes to a certain repository, and we are able to extract de-identified data so that we can use that for reporting purposes. Aside from the very, very broad, governmental regulatory requirements, hospitals also have different patient treatment data monitoring needs and requirements. So some of these would be hospital-wide, such as length of stay. So the length of stay measures the time between the patient is admitted to when the patient is discharged. And it is an expression of, or a measurement of how efficient the facility was able to provide care. So the longer the length of stay, that, it seems the less efficient the care would be. But of course, within each patient are always different other considerations, right? Because some patients have shorter length of stay because they don't have comorbidities or they don't have too many conditions happening at once. But in general, hospitals measure length of stay. Other data that we extract could be in a department level, or so some of it is, or a lot of it is related to electronic health record use. So a department such as nursing or even to the unit level might measure how often their nurses are using barcode medication administration when they give the medication to the patients, because they've implemented certain programs or functionalities to help keep the patient safe. And one of them is barcode medication administration, right? You don't have to keep guessing what the medication is, so you come into the room, you identify the patient, scan the patient's ID bag, and then you pick up the medication and then scan the medication, and then the administration goes into the electronic health record. Now, nurses still are expected to use their critical thinking skills when they identify something is not quite right with either the patient information or the medication information. But in simplest terms, there are those functionalities that help nurses and other care providers, other clinicians provide safe patient care. And hospitals can track and monitor how often or what the compliance is to using those particular functionalities. Does that make sense? Other things that hospitals might measure are how often patients get hospital-acquired infections or hospital-acquired conditions. So for example, one of these is catheter-related urinary tract infection. So when a patient comes into the hospital, we expect the patient to get better, not to get sicker, or not to get another kind of disease, right? So those things, those are actually also measured under the core measure set, but those are some of the ways that hospitals specifically measure how well treatment is being given. So another category, and I should have said that all these categories are actually interrelated. So it's not, something that is in one category can affect other categories. And in the last category, which is compliance to regulation, is actually overarching all of this. So for payment, there are actually a lot of other data metrics for financial health for hospitals, but here are some examples of what data are being extracted and monitored. Okay, this is not number one. This is not 1 day, but just days in accounts receivable. So this measures the amount of time between the patient discharge and when the hospital receives the payment. And this actually reflects or impacts cash flow. So that is something that most hospitals track. The timely filing of claims to payers. So we have, your insurance payers, we have your government payers, and some they have different deadlines for filing claims, and so delays can cause denial. So even if a hospital is 1 day late for submitting a claim, that can be grounds for a denial, and then that impacts your bottom line as well. Let's just share something about that. So payers have different timelines. So it's actually very complex because some private payers or insurance have shorter timelines than the government. So they have different ways of tracking that, and that data is really important as well. So readmission rates is the number of days that patients, so there's a missing word here. This is the number of days that patients are readmitted, or the number of patients that are readmitted within 30 days of being discharged for the same condition. So you would think that this is a reflection of treatment, and you're correct if you think that. But this actually has a financial impact as well, because hospitals with the highest readmission rates are penalized by Medicare. And so there are many other ways that financial metrics are tracked. And we can give more examples about that. So how about operations? So operations are how the hospital is run. And there are many data needs for operations. These are just some of the few that most hospitals use. So each hospital has a different way of tracking data. But one of them is census. So census is how many patients do we have today. And you can be tracking overall census, but what's really helpful is also tracking departmental census, emergency room census, number of OR cases, because that is all interrelated, and that actually helps the hospitals move patients and make decisions on how to be more efficient with patient movement. Therefore, that also helps provide better and more efficient care, because you don't want to have patients, and some of you might have experiences, sitting too long in the emergency room to be seen, because there's a lot of patients in the emergency room that could not be moved out. And that segues to another way that hospitals use data, which is throughput. So aside from the overall census, hospitals can also be measuring admissions and discharges. And one of the ways that you can get more patients in is to be able to send some of the patients home, right? Discharge them to home or to another facility, skilled nursing facility, long-term facility. And so if there's somehow a blockage in that process, your data will be able to help you identify those blockages, and then leadership and even clinicians and other support service staff can then help clear those blockages and improve the throughput. And so we also have staffing, right? If you have a high census, of course you need more staff to come in to be able to give safe patient care, and even support services turnaround time, like housekeeping. How quickly is housekeeping able to clean a room? And that actually also helps move patients faster through the process of getting admitted and given care, as well as many others. So I have 1 more minute, and giving you a heads up that the next slide is a word salad. So there are a lot of regulatory standards that govern how hospitals are run. And one of the most important is the CMS TOP, which is the conditions of participation. We also have California Title 22, and these are the standards that govern how the hospitals need to measure up to so that they can continue to be a part of the Medicare and Medicaid programs and the Medi-Cal programs. The HITECH Act of 2009 pushed for the adoption of electronic health records, and that actually has helped hospitals be able to see and monitor their data better. The MACRA and the MIPS have switched the philosophy from pay for service to pay for value. So meaning, did the patient's outcome improve? But within these programs are a lot of reporting requirements. So based on these reporting requirements, hospitals are reimbursed in a certain way, so they have a formula to do that. And so by meeting these standards, hospitals not only are able to stay within the program, but also the way their ability to meet their standards has an impact on their bottom line as well, and their operations, and the ability to give care to patients. So that's it. Very, very quick presentation. I hope that I was able to give you a glimpse of how the healthcare industry, specifically hospitals, use data, and maybe piqued your interest in the healthcare industry.
Questions?
Yes.
Have you noticed any interesting trends in any of your data since the ACA was put into place? The Affordable Care Act?
Do you mean like
Just anything interesting you noticed, like in terms of changes in...
I particularly haven't seen like wide-ranging data because I have a specific role. So I think maybe more leadership, operational leadership, would see these higher level trends.
So you usually a nurse, how do nurses interpret the data, and what kind of data products are like they and the doctors looking for?
That's a very good question. So when I was in clinicals, the data that I needed was very specific to the care that I was providing to my patients. And so we would have departmental specific data, like when I mentioned that if a hospital is tracking hospital-acquired infections, for example, catheter-related infections or ventilator-related pneumonia, which is something that we track in the critical care unit. So if you have the data and you see a trend, so that the management and leadership can then come back to the nurses and doctors and have a discussion and say, over the past few months, our ventilator-acquired pneumonia, for example, has been rising, and we need to address this. So the more the data is within your fingertips, the faster clinicians and management can respond to it to provide that patient care. Does that answer your question? Any other questions? All right, thanks for listening.